during this period where they keep on, and we'll guiding them, both the examiners will guiding them how to present, and Kaladhar will be taking the questions if the participants there will be keep answering the questions in the platform, and sometimes also have queries to them.
Yeah. Sir, it's live, sir, now. We are good to start.
Okay, please,
So,
Kaladhar, go ahead.
they both present the case, is it?
They both present together, ma'am. It's not as two separate cases. They present the same case together. They can participate together or one after the other.
Questions, okay.
Okay, we'll start. Yeah. Good evening, friends. Welcome to our Tuesday webinars from the Department of Critical Care Medicine, Yashoda Hospitals. So today's masterclass webinar topic of discussion is subarachnoid hemorrhage. Everybody knows it is a CNS emergency wherein the critical care aspects are very important in approaching to these type of patients, right from the presentation, diagnosis, and management part. So to discuss this topic, we have with us Dr. Bhuvana Krishna, ma'am. Madam is professor and head of the Department of Critical Care Medicine at St. John's Hospitals, Bangalore. She is a renowned expert, and Madam is a very senior and seasoned, very well known. We listen to her talks, very crisp and straightforward. Welcome on board, ma'am.
Thank you.
Thank you for yeah, it's an honor. So we welcome Dr. Saroj Prusti, sir. Is the head of the Department of Critical Care Medicine at Virinchi Hospitals, Hyderabad. So I think he will be joining in a bit. So to discuss this topic, we have Dr. Preethi and Dr. Dhanushree. So they present the topic. They are DrNB residents from Fortis Hospital, Bannerghatta, Bangalore. So welcome, Dr. Preethi and Dr. Dhanushree. You can start the presentation.
Sure. Thank you.
We have Dr. Venkat, Raman, Kola, sir. Sir, do you want? Yeah.
So I'll start, sir.
Yeah, please proceed.
So today we'll be discussing about subarachnoid hemorrhage case presentation. So I'll be starting that. So a 61-year-old female patient presented with sudden onset of severe headache, which was diffuse and which did not subside on any medication. This was followed by one episode of vomiting, and also they gave a history of altered sensorium. All this happened on 25th of July. And associatedly, she didn't have any history of fever. There was no history of neck pain or any history of trauma. So the past history is she didn't have any history of similar complaints in the past. She does not have any known comorbidities. Personal history, she's a homemaker with who has attained menopause, and bowel and bladder habits are regular. Family histories, there's no similar similar complaints in the family members. So with this complaint, she was taken to a private hospital in Bangalore.
Can I stop you here?
Yes.
Just from the history, what extra information would you have liked to ask?
How intense was the headache? Like she presented with a history of headache.
Go back to the first slide. I can stop them to ask questions, no? Just like in the website examination.
Yes, ma'am. Yes, ma'am. Yeah. You can, at any point, you can stop and ask the question.
Yeah, because just to get, hang on how to take a history in a patient with subarachnoid hemorrhage.
Yes, ma'am. Yeah.
So her main complaint was the history of headache. So we'll ask her as attenders how severe was the headache, whether she had any preceding episodes of headache, and how worse was the headache, the intensity of the headache, and the maximum intensity, how soon did the maximum intensity reach, and was there any relieving factors? These are the things which we ask regarding the headache.
Isn't it important to ask duration also? How long did she have the headache before she lapsed into altered sensorium?
Yes, that is also, yes, ma'am.
Yeah, because it will tell us what investigations to do. So that's very important. And any other important relevant history here?
Any history of giddiness or loss of consciousness? That is one relevant history, ma'am. Or any associated history of trauma, neck pain.
And anything else that you would like to ask?
Also any history of fever, if she had any history.
That is there. No history of fever, neck pain, or history of trauma is there. Seizures?
Yeah, any history of seizures.
So that's important. And I think there's there's a history of whether any similar complaints were there in the past.
In the
That's
past.
also very important. Why is it important?
So usually in the case of SAH, they'll have prior headache episodes called as sentinel headaches, which
Yes.
give an indication that they'll have it in future, like they'll have a bleed in future.
Okay. Anything else?
If the patient is having a migraine history, that to differentiate between the other causes of
Yes.
the headache. So
So-
migraine history or previous ruptured aneurysm. So if she had similar episodes or intracranial hemorrhage previously, so they can have a similar presentation previously.
Correct. So it is important to ask if there has been previous history of headaches, which could be other than a subarachnoid hemorrhage. So with this history, with the extra information that you would have liked to ask, what would be your DDs, your order of DDs? Because
So
it's
most-
very important with the history in any exam, they will ask you. This is like a summary. After this summary, you will have to give your TDs.
So with the acute onset of headache, with altered sensorium and vomiting, so my first differentials will be intracranial bleed, either SAH or intracerebral hemorrhage, or it could be migraine episodes or infectious causes like meningitis or
How
brain
often
abscess,
do
which is
you, sorry, I'll interrupt you. How often do you see a migraine with an altered sensorium?
not often.
Yeah, it's not very common. So I wouldn't want to keep that at all in my second DD. As you said, intracranial hemorrhage, either SAH, ICH is definitely taken. Any other?
Cerebral venous thrombosis might also present in a similar way.
So you probably need to take a little more history there, right? Just
Yes.
not fever, neck pain, maybe any diarrhea, any signs of dehydration, volume loss also, you may need to take if you're thinking of CVT.
Yes. Infectious causes like meningitis or brain abscess.
Brain
Uh,
abscess going on so fast, not
Yes,
unless-
yes.
Yeah, fever, neck pain, so any kind of a neuro infection also that you may need to look at.
Yes.
Stroke, would you want to take a cerebrovascular accident like a stroke, acute ischemic stroke?
Acute is the initial onset of headache followed by a deficit is rare in case of acute ischemic stroke.
Yeah.
It's more of a deficit followed by other symptoms.
Yeah, so you wouldn't want to keep that, in that. So it's all pointing towards an ICH intracranial, hemorrhage, which could be either ICH or, subarachnoid hemorrhage. Okay, please
Yes.
continue.
So with this complaint, she was
One
taken
more
to-
thing I think I need to tell you is you need to ask about comorbidities. I don't think it's mentioned there.
Mentioned.
we in the past history we have mentioned.
Comorbidities, like especially hypertension.
Yes.
Oh, so that is something that you need to keep in mind, that many a times they might not have even, evaluated, or they might have had one stray incident saying that I had high blood pressure, but I just ignored it. So you need to take the comorbidities into consideration.
So with this complaint, she was taken to a private hospital where she was on initial assessment. She was intubated there in view of low GCS. So there on presentation, it was mentioned that she had a GCS of V2, V2, and 5 with pupils which were bilateral equal and reacting to light. With this, once airway and breathing is stabilized, they had and circulation is stabilized, they had mentioned that they had taken her for CT angiogram, which revealed an aneurysm at the left ICA bifurcation with subarachnoid hemorrhage. And in this same hospital, DSA was done and clipping was offered to the attenders.
Okay, so let's stop here and discuss a bit more. Somebody has raised their hand. Can we ask them to unmute and ask, or is it?
Ma'am, we can actually continue the discussion. They
Continue
can
the discussion
enter in
later.
on the chat box. ma'am.
Chat box, okay, so they can put their questions on the chat box, okay. With this, what do you think, is this the right way of having to evaluate this patient? Patient has gone for a CT angiogram. Would that be your first step of, imaging?
Generally, a non-contrast CT is indicated as a first first investigation of choice in evaluating these cases. Ma'am.
Yeah, so I think that would
Yeah,
be the
done.
first step, isn't it?
Okay.
So a non-contrast CT scan would be the,
Choice of first investigation.
maybe they did it and they would have completed the study with the CT angiogram.
Yeah.
So even if you're suspecting our first DD was an ICH or an SAH, so non-NCCT would be the first imaging of choice. Okay. Anything else you want to comment? When would you go ahead to do DSA? Would the NCCT and CT angio, would it be sufficient, or do you need to go ahead and do an DSA?
DSA is a gold standard test for the aneurysm, to localize the aneurysm, to measure the size of aneurysm, and to see what is the type of aneurysm. And mode of treatment will be depend on type and size of the aneurysm and location of the aneurysm. So when we plan to intervene the patient, DSA will be the investigation of choice. Ma'am.
And another question, what do you think would have been the cause for, they've picked up the aneurysm, what could have been the cause?
She is not a known case of hypertensive, and she is a female patient with age more than 55 years. So with this risk factor, she might have had a berry aneurysm. So
how do you divide the causes, the etiology of SAH? How would you want to classify the etiology?
We divide it into aneurysmal and non-aneurysmal cause of SAH. Ma'am.
Okay.
So aneurysmal is the most common is berry aneurysms, which are there.
So how often or how common is aneurysmal SAH?
in SAH, 70% are aneurysmal SAH, ma'am.
More than
And
70%.
10% are 10 to 15% are perimesencephalic SAH.
Yes.
And rest are because of AV malformations or traumatic SAH.
Traumatic would be the other common cause. Okay,
Yes,
so
ma'am.
that's a little, but you do see a lot of SAH due to trauma also.
Yes, ma'am.
So, but a significant number, if there's no history of trauma. If there's history of trauma, it will become automatically a traumatic cause. But if there's no history of trauma, as given the first slide, and you need to think of aneurysm, and if your CT angio doesn't pick up, then you need to look at DSA, which is your gold standard.
Yes.
Any other test would you do? Is there, what do the guidelines say? If your CT is normal, what do you do next?
If the patient present within 6 hours, CT will be more sensitive and specific. Sensitivity will be around 98 to 99%, and specificity is around 99 to 100%. No need to do any further investigation if the CT is negative within 6 hours.
Yes.
If the patient present after 6 hours of symptoms onset and CT is negative, we'll be going ahead with a CSF analysis for xanthochromia.
So why do you wait for the 6 hours? Why this demarcation of 6 hours?
The studies have shown if the thin SAH is there, it will resolve, and the sensitivity of the CT over a period of time reduces.
That's because of your RBC lysis.
Yes.
So you may not be able to pick up. The RBC is the one which helps you to detect it on CT. So more than 6 hours, because of the RBC breakdown for a small SAH, it may not be evident. So that's when you look for the xanthochromia.
Yes.
Anything else you want to tell us about the modality that was offered here?
That's it. Clipping was offered, ma'am. So, I mean, after the DSA, usually if it is accessible, we prefer calling rather than clipping. And especially when this patient is an elderly patient. So, if it is accessible, calling is a preferred mode.
And one more point to see in this is it is present in the bifurcation of the ICA and the posterior communicating artery. When the aneurysm is in the bifurcation, the coiling may not hold for a long time. So clipping will be advisable when there is an aneurysm in the bifurcation. So I think clipping will be better with this DSA picture.
Probably that is why they have offered.
Yes, ma'am.
But before we go on to CT angio, then the clipping that was offered, what you should not forget in the management of these type of patients.
So airway breathing circulation should be stabilized.
That should be
And-
the primary thing before even with a 9 GCS.
Yes, ma'am.
What would you have done before shifting the patient for CT scan?
Secure the airway, intubate the patient, secure the airway. and then-
Yes, so that should be definitely have been, instituted. Anything else? Would you be interested to know anything else? Is it there in the next slide? I'm not sure. Next slide. Then what? So they've already gone to looking at shifting the patient to another hospital. So go back to the first slide. What else would you be interested in? One is the etiology. Then you want to secure the airway. Then anything else?
Any features of seizure or raised ICP to be noted, and the measures to control the raised ICP should be taken on, like keeping a patient in a head-up position, avoiding struggling by giving a sedation if required to cooperate with a ventilator, and osmotic therapy can be initiated before shifting if there are signs of intracranial hypertension. So generally we use 3% NaCl, even the mannitol can be used.
Is one better than
And
the other?
keeping on R marks here. Sorry, ma'am.
Is one better than the other?
There are no studies shown one better than the other. So the guidelines suggest either of one can be used. But side effects with the mannitol is it causes osmotic diuresis, where the hypovolemia chances will be higher. So if you are keeping a euvolemic state with adequate IV fluid resuscitation, even mannitol will be equivalent to 3% NaCl.
Yeah.
And keeping a normoxia, normocarbia is important.
Some very important vital you are missing here, especially with respect to SAH.
GRBS,
blood pressure.
blood pressure monitoring.
Yeah.
And
Blood pressure is the most important here. Okay.
Mm.
So what would be interested in? What blood pressure would you be interested in?
there are no specific, there are no studies which are shown specific blood pressure is good in case of SAH patients. The one thing we have to avoid is making them hypotension or fluctuating blood pressure, which are shown to be detrimental in these patients. So there are studies which are done in intracranial hemorrhages, like INTRACT-2 and ATTACH-2 trials have been implemented in this SAH also. So generally we keep a blood pressure around 140 mm of Hg systolic blood pressure. But in a higher grades of SAH, where intracranial hypertension would be higher, in such patients, keeping a higher MAP will be beneficial to provide the adequate cerebral perfusion pressure.
How high?
So at least the MAP of more than around 80 mm of Hg will be needed to keep the cerebral perfusion pressure.
Yeah. So that's an important point, but you need to note that the blood pressure targets are different with respect to in the acute phase before the definitive intervention or the aneurysm has been tackled. So
Yes.
you need to keep a target similar to an ICH in order to avoid rebleeding.
Yes.
So that is why you need to keep it, as you rightly mentioned, you need to keep it at 150 or even 160. They have seen both 160. Some have mentioned even 180, but then better would be like for an ICH, 160 to 140 range systolic blood pressure. Okay.
Yes.
But as you said, there are no clear-cut studies supporting one particular blood pressure target, especially in the acute phase. But there is a different target in the later phase, which we'll discuss later. But that's very, very important to prevent rebleeding. You have to target this blood pressure. Another very important point which you mentioned is you need to avoid fluctuations in the blood pressure. That's very, very important. That has shown a higher mortality when there is wide fluctuations in the blood pressure. And rapid reduction is also to be avoided. That is also like in an ICH, actually, you would want to bring it down rapidly, no?
Yes.
That is to be avoided in an SH. Okay. And it should be a very gradual, but they don't mention how soon, how gradual. That is not indicated clearly. There's still more studies that need to be mention? I mean, to be done to get to the exact blood pressure and how quickly you need to bring it down.
Yes, ma'am.
So what is the risk of rebleeding? When is it, and how high are the chances of rebleeding?
The risk of rebleeding is usually higher in the initial 24 hours, ma'am, in between 12 to 24 hours. That is the highest.
48 hours, up to 48 hours. And
Then as the day, as the longer the duration, the risk gradually decreases by 1%. So it usually reaches, by 2 weeks, it is less than 50%. Very less.
Within 24 hours, it is about 4%. And after that, every day, around 1% per day risk will be there, 1 to 1.5%. And by 2 weeks, 20% risk of rebleeding will be there.
and what are the identifying risk factors for rebleeding? If you were to see the CT, if the CT was there, how would you know, okay, these patients are at high risk of rebleeding?
If the aneurysm is in the posterior circulation, increases the risk. Hydrocephalus is present, and higher grade of World Federation neurosurgical grade or CT severity score. So increases the risk of rebleeding, ma'am. And larger the aneurysm, multiple aneurysms, and BP being not controlled, or if the patient is
That's
having
the most
seizures.
important. Very high blood pressure uncontrolled, that will also increase your risk.
Yes, and seizure episodes will increase the rebleeding.
Yes, correct. So as you mentioned some, prognostic scales. So which are the ones that you would use? If the CT was there and you have the clinical presentation, so which ones would you use?
So in the clinical, most commonly used is the World Federation neurosurgical scoring system and Anton Hess. So World Federation, it includes two components. One is GCS and the neurological deficit. It has 5 grades. Grade 1 is GCS.
For this patient, what would be her WFNS score?
It is grade 4, ma'am.
Yeah.
Her GCS is 9. With or without a deficit, it comes into grade 4, ma'am.
Yeah, correct. I think 7 to 12, isn't it? WFNS is
yes, ma'am.
grade
7
4
to 12 is a
7
grade 4.
GCS, yes. We don't know her deficits, but
Mm.
then with her GCS, we can FNS, so 12.
Yes.
Shall we go to the next? Any questions, sir? You want to ask any questions?
Yeah,
Been asking all the questions.
Thank you. Thank you. Good evening, everyone.
Good evening, sir.
Regarding related to hypertension, I need to ask. I just wanted to ask because your target is keeping the sister, as Madam told that we need to maintain around 160 or below 160. That is most ideal cases. So suppose you need to reduce, BP is higher side, you need to reduce. How you want to reduce? Which drugs you will prefer and which drugs you need to avoid?
We will be using most commonly the labetalol. We'll give 10 to 20 mg IV as a slow bolus followed by an infusion 20 to 40 mg per hour to control the blood pressure, sir. So generally, we need to avoid sodium nitroprusside and NTG. So because it increases it causes cerebral vasodilation and increases the ICP.
So
and if nicardipine, yes, sir. If nicardipine is available, can be used, and even the hydrolazine can be used. But we commonly get labetalol and we use labetalol.
So, okay. If you have an option for giving hydrolazine, can you give hydrolazine? If there is a severe person is having severe and means HS scale grade 4 or grade 5, and there is extension of subarachnoid hemorrhage to intraventricular hemorrhage and ICH, intracerebral hemorrhage, and patient is having hypertension 180 or 200 systolic blood pressure. So will you prefer, you are given option of giving hydrolazine. So can you consider for giving hydrolazine? You are correct for NTG and nitroglycerin is to be avoided because of direct vasodilators and which increases ICP. Even only for subarachnoid, pure case of subarachnoid hemorrhage, you can use the hydrolazine. But if it is associated with intracranial hemorrhage, intracerebral hemorrhage or intraventricular extension, better to avoid hydrolazine. Other drugs, nicardipine, your labetalol, nicardipine, and other drugs you can utilize. but better to avoid hydrogen if there is associated intracerebral.
Okay.
And coming to that evaluation, when you are considering for a DSA, when you want to go for a DSA, this patient.
So one is when the CT angio is not confirmatory, or when the intervention is planned. So to see the size, type, and the exact location of the aneurysm to decide on what type of intervention to be done. So.
Okay, you can go ahead.
How soon should you do the intervention?
As soon as possible, guidelines say within 24 to 72 hours.
72 hours? I mean, they have been, it says as early as possible within, 24 hours,
That's what.
but definitely not, going into the time when DCI may start. Then it may be difficult even to do the procedure. So it should be done as soon as possible.
Yes.
Okay.
So on arrival in our hospital, on examination, airway was secured with an endotracheal tube. Breathing, it was assisted. Patient was on ventilatory support on PRVC mode of ventilation with FiO2 requirement of 0.3 with a tidal volume 400 ml and respiratory rate of 18 per minute with PEEP of 5 centimeters of water. With this, she was saturating 96%. On examination, she had bilateral normal vesicular breath sounds. Coming to circulation, she was hemodynamically stable with a heart rate of 92 beats per minute and a BP of 130 by 80 mm of Hg. Coming to general physical examination, she was moderately built and nourished with a temperature of 98.2 Fahrenheit. There was no signs of pallor, icterus clubbing, cyanosis, edema, or lymphadenopathy. Coming to neurological examination, her GCS was E3 VT M5. The pupils were bilaterally 2 mm equal and reacting to light. Cranial nerve examination. Since she was on ventilator she was not obeying commands, we could only assess the reflexes, which were pupillary, corneal, and gag reflexes, which were present. On neck flexion, resistance was present. Motor examination, the power bilaterally it was equal, and there was movement against some resistance in all the 4 limbs. It was a power of 4/5 was present in all the 4 limbs. And sensory examination, only sensation of pain could be assessed, which was felt on all the 4 limbs. Bilaterally it was present.
Sorry, I can't see your slides.
No. So everyone cannot see now, or sir, can you see?
We can see.
Okay.
Can you escape the full screen and again
Yes.
put it back? Yeah. Is it okay now?
Yeah.
Is
Yeah,
it visible?
no. Yeah, I can see now.
So that is about neurological examination. Coming to respiratory system, like I said, she was on PRVC mode of ventilator with bilateral equal air entry. Hemodynamically, heart rate 92 beats per minute, so BP of 130 by 80. All other systems were normal. Coming to investigations.
What sedation would you choose for her? You have to keep the patient on the tube, no? What analgo sedation would you choose?
We use fentanyl in this patient as the BP is normal, and for analgesia and sedation, fentanyl will be better. So we generally start with 30 microgram per hour as an infusion, and we'll taper to her sensorium.
Okay. Anything else? Suppose if the the patient needs higher sedation, is restless, struggling.
With the normal blood pressure, we can use the low dose of midazolam propofol, chances of hypotension will be higher. So I'll be avoiding the propofol. If the BP is on the higher side, even the propofol will be better to control the blood pressure as well as for the sedation, ma'am.
Because
And
if you are going to use midazolam, then your assessment of GCS will be hampered. Your
Okay.
neurosurgeon is not going to be happy.
yes, ma'am. Dexmedetomidine is can be used in these patients. It decreases the pain as well as makes the patient calm, and it does not alter with the GCS compared to the midazolam and other agent.
Yeah, better would be propofol. If small dose of propofol would help. You can quickly stop to assess the GCS. If the patient has raised ICP, how do you recognize at the bedside? Does this patient have raised ICP?
When she presented, she didn't had, ma'am. So
How do you know? How do you know?
So clinical examination, generally they might present with a Cushing reflex of bradycardia, hypertension, and altered respiratory pattern, and pupillary asymmetry can be present. And if the patient has developed acute rise in the intracranial pressure, there could be a drop in the GCS as well with the neurological deficit, new onset of neurological deficit, which can be seen. And then bedside examination, I mean, the investigation test, we can see the pupillometry, I mean, the optic nerve sheath diameter to see for the optic nerve sheath more than 5 mm indicate there is a raised ICP. Or if the fundoscopy can be done on the bedside, even the fundoscopy will be helpful. And even the transcranial Doppler, where there is a reverberation of the flow, diastolic flow will be altered. So even that can be noted, ma'am. And other investigation like EEG and radiological imaging, that is CT scan, can be helpful.
So if you have any of these tests at the bedside suggestive of, raised ICP, you would go in for the CT imaging, re-imaging to see what's happening.
Yes.
Yeah, correct. Rightly mentioned. Yeah.
And in this person didn't have any focal neurological deficit, I think so.
She was moving all 4 limbs, sir, but
Okay.
other things like aphasia, hemianopia, all those things could not be assessed. So only the motor limb deficits were not noted, examined, and it was not present.
Okay.
Are there any, scales or scores to help you to predict these patients are at high risk of rebleeding? Probably it would be more from a patient who's conscious and maybe telling you. You've heard of an Ottawa scale?
Yes, ma'am.
Okay, so maybe you can, but you may not be able to apply it much in our ICU patients also, because there's neck pain, or if the patient has developed, worsening GCS. Okay, yeah. You can continue.
So coming to investigations, her hemoglobin was 10.2 gram per deciliter. Total count was 9,000 per cubic millimeter. Platelet counts were 2.3 lakhs. Creatinine of 0.61 milligram per deciliter. Serum sodium of 139 millimole per liter. With serum potassium of 4.37 millimole per liter. PT was 13.6 seconds and an INR of 1. Her GRBS was 140 milligram per deciliter. Her ECG was normal. 2D echo showed no regional wall motion abnormality with the ejection fraction of 60%. Her liver function tests were normal. And her ABG showed a pH of 7.38 with PCO2 of 36, PO2 of 88, bicarb of 20, and lactates of 0.8. And the EEG which was done showed a diffuse flow wave dysfunction.
Are you happy with all these parameters that they have shown? HB 10.2, you're happy?
Yes, ma'am.
So what's the target for a patient with SAH?
So there is no clinically, I mean, according to the AC guidelines, there is no defined target for hemoglobin. Generally, like we use for other ICU patients, we use a target of 7 HP only. But then if it is patient of higher grade of SAH, which is seen on CT, with a thick SAH and all, then we will consider transfusing. Or if there is a serial drop in HP, which is significant, then we'll consider transfusion.
No, what would be your target? So for 10.2, you're going to transfuse, or 9 to 10 is fine?
10.2 we won't be transfusing.
Yeah, so otherwise it is usually 7. There's not been any evidence, whatever studies have shown, there's no benefit of keeping a higher hemoglobin. But I think world over, all neuro ICUs, they target range of 9 to 10. I don't think they'll be happy with
Yeah,
7 as the target.
Acute neurological injury, it is target is 9 to 10.
So a
There.
lot of case reports have been favorable for 9 to 10.
Yeah, correct.
Okay. What about others? Platelet counts are okay? Counts, creatinine.
Yes, ma'am, all of them.
What about sodium?
Here sodium is within normal range, but if we are planning for osmotherapy with the 3% NaCl, then we will be targeting 145 to 155 range. If we are planning for mannitol, then we will be looking at the serum osmolarity, and normal sodium of 139, we will be accepting it now.
So suppose if the patient you were giving 3% saline,
Yes,
because you didn't want to cause fluctuations in the, volume status. What would you do? You were giving 3% saline, this is the sodium.
So we'll start with a 3% saline bolus. So generally we start with 5 ml per kg body weight. And in our ICU, we continue with an infusion. So we'll give 5 ml per kg body weight and continued with an infusion of 0.5 ml per kg.
Yeah.
And infusion, and every 6th hourly we'll be monitoring the serum sodium to keep a target of between 145 to 155
You
millimole
should
per
try to
milliliter.
achieve the sodium as early as possible.
Yes.
So you need to keep giving boluses. There's no proper protocol that has been suggested. So you can give it as boluses, as you said, you can give as infusion also. It is based on your ICU practice, and try to reach 145 as soon as possible.
Yes.
INR, potassium and all are okay. You're happy with it?
Yes, ma'am. They're all within normal limit.
Yeah. So the patient has to go for surgery. I think she is ready for any procedure. What about sugars?
Sugars for any neuro patients will keep within less than 180 milligram per deciliter. So it is within normal limit. So we'll be checking every 6th hourly. So if needed, we will give a insulin according to the sugar level values.
So 140 to 1.
Whether we need to check every 6th hourly or more frequently.
If we are using a mannitol, then more frequent sugar monitoring will be required, because mannitol can cause hyperglycemia, sir. So otherwise, without the patient is not a diabetic, so 6th hourly monitoring will be sufficient.
Because sugar fluctuation risk is very high, and hyperglycemia both are risky for complications. So mortality is also very high, even the fluctuation in the blood sugars. So we need to monitor more frequently. You can monitor every 2nd hourly.
Okay.
In the initial phase, critical phase.
Okay.
And here you saw ECG is normal in your patient. Suppose you found next day, you found that, or after a few hours, you found that ECG is showing diffuse T wave inversion. And patient is in altered sensorium. Patient, you do not know whether a patient is having chest pain or not. And you have sent the tropi is positive. So what we will do next?
So ECG changes in case of SAH is common because of increase in the sympathetic activity and dysfunction of the parasympathetic activity. And there could be ECG changes as well as a regional wall motion abnormality, which could be noted. But in the acute phase of SAH, no intervention can be done, even if there is a thrombotic myocardial infarction. So in such patient, we will try to secure the aneurysm first, and later we will be planning for the cardiac interventions. And we will try to keep things, the normoxia, normocarbia, and avoiding fever and avoiding exertion. All these measures will be taken for neuroprotection as well as cardiac protection.
Okay. What are the specific ECG changes which happens in subarachnoid hemorrhage, and how to differentiate ECG changes of acute ischemic subarachnoid hemorrhage from your acute MI?
They'll have QT prolongations, T wave inversions, STT changes, ventricular premature complexes, and also which might also be seen in MI. So the pattern of T wave inversions or T wave elevations is a differentiating between the myocardial ischemia and the SAH. I think in the myocardial ischemia, it's narrow based and more acute.
Yes. So in myocardial ischemia, you will get narrow T wave inversion, whereas in subarachnoid hemorrhage, you will get a wider T wave inversion. And another, the most important thing is you will get a diffuse T wave inversion in subarachnoid hemorrhage, whereas in MI, you will be artery specific T wave inversion and ST changes. And usually, ST reciprocal changes you will see in the MI, you will not see reciprocal changes in the subarachnoid hemorrhage. QT prolongation also will be more specific to the subarachnoid hemorrhage. QT prolongation may not be there in MI. So in that way, clinically, by looking at ECG, you can differentiate because in both the conditions, ECG changes will be almost similar and drop I may be positive in both the conditions. But still, we need to differentiate whether post-procedure, after going for intervention for subarachnoid hemorrhage, whether you should go for a NGO or not, coronary NGO or not, you need to take a decision. Okay.
What is the commonest ECG abnormality in SAH?
STT changes, ma'am. I mean,
Is it STT changes or something else? What percentage of the SAH patients have these type of ECG changes?
More than 40% of them have ECG change.
40% is too high.
not sure. ma'am.
About 5 to 10%, not very high. And among them, maximum are arrhythmias. And then you have all these type of STT changes. And echo can show even stress cardiomyopathy. So these are the findings. That's why it's very important to look at the ECG and 2D echoes.
Yes, ma'am.
What about the ABG? You're happy?
Yes, ma'am. She was on 30% of FiO2. So PF ratio is approximately 290. And PCO2 is within normal limit, 35 to 40, so 36. So, and there is no metabolic, not significant metabolic thing. Bicarb is 20, lactates are normal. So
Looks
we are
good.
okay with the ABG, ma'am.
Yeah. What about the EEG? Is the EEG an important component in SH and monitoring?
Yes, ma'am. So one thing it tells about the brain activity. So if there is a depression of the alpha wave and alpha to delta ratio is decreasing, it signifies that there is a high degree of SAH. And also it shows epileptic form discharges. Non-convulsive seizure can be documented with the EEG. It is an important modality.
Yeah, correct. Anything else you would want to use apart from what is mentioned here for monitoring?
So on the bedside, we can do the transcranial Doppler also because she presented on the 4th day of her symptoms. So the vasospasm will be starting from the 4th day most commonly. So even the transcranial Doppler will help us to know whether she is in DCI.
So I think that's another very important tool apart from your neurological examination to pick up complications of SAH. TCD is also a very useful tool, and your EEG also.
Yes, ma'am.
Okay, shall we go next slide?
Yeah, here I want to ask one question.
Yes.
This patient, you are looking at this ABG and patient PF ratio is around showing 290 or 300. Suppose this patient came to you in a aspirated condition, low GCS, having severe ARDS. So you need to ventilate, you try to ventilate. So now patient needs a higher PEEP, higher ventilator support, higher sedation and paralytic agents. So how will you handle this situation, this patient having a severe subarachnoid hemorrhage, severe grade SH?
So if the patient is having severe ARDS, if we give a little higher PEEP also, it won't be transmitted to the extrathoracic organs. So the PEEP up to 8 to 10 can be applied in this patient, sir, if the patient is having an ARDS. And some studies have shown that even the proning can be done in case of SAH. So when there is a requirement, when the PF ratios are not holding on with a severe ARDS, proning can be done. So we will go with a little higher PEEP, and needed proning can also be done. Sir.
So can you go for a recruitment maneuver for oxygenation to improve?
No, sir. Recruitment maneuver. I'm not sure about the studies, but we will be avoiding the recruitment maneuvers.
Because proning also, when whatever intervention you do, either keep little higher PEEP or proning or something, definitely there will be risk for increase in ICP, intracranial pressure. So in these patients, if oxygenation is our target, how much oxygenation is you want to keep for this category severe ARDS patients in cases of SAH?
There's no target of oxygenation, but we will be interpolating what we use in the traumatic brain injury. So PaO2 of 100 is advised in case of traumatic brain injury. But in this patient with a severe ARDS, keeping 100 PaO2 might be difficult. At least keeping a saturation more than 92 to 94%, 94%, and PaO2 more than 80 might be acceptable, sir.
Yeah, correct. So your target of SpO2 more than 92% is correct, but to monitor ICP is more important here. If whatever the interventions are required, which might increase the ICP. So to control the ICP, if you monitor ICP along with the ventilator support, whatever the parameters you are doing, which is indicated those who are having associated severe ARDS.
Sure.
Yeah. ICP you don't monitor in the routine in all cases of subarachnoid hemorrhage.
Yes, ma'am.
If it is associated with severe ARDS with ventilator, these parameters are required. So probably we need to go for a ICP monitor. Okay, you can go ahead.
So next is CT brain plane was done, which showed a ruptured left ICA bifurcation aneurysm with acute subarachnoid hemorrhage. There was a bilateral periventricular and central semi-oval white matter hypodensities with extensive subarachnoid hemorrhage involving the suprasellar cisterns, bilateral sylvian cisterns, and left frontoparietal convexity cisterns, and a hematoma involving the fourth ventricle. The modified Fisher scale here was grade 4. So
Can you show the CT brain? There's an image of it. Yeah.
only one part of it.
So based on this CT, if you had not got the report, you had just taken the patient for the CT, can you identify where the aneurysm is?
And no aneurysms, ma'am. Actually, here the SAH is seen in all the areas like interhemisphere, in the sylvian fissure, in the lateral ventricle, as well as in the cerebral cortex. So when it is an extensive, we won't be able to identify the site of aneurysm.
Look at where is the blood mainly concentrated? It's not in the, basal cisterns, right? The major concentration of the blood is not in the basal cisterns around the fourth ventricle. It's in the left sylvian fissure. Can you see it?
Yes, ma'am.
I can't show you. You can use your eyes.
Yes,
Yeah. That's where it is. If it was in the posterior circulation, you would have seen blood mainly in the basal cisterns. Where would that be? Can you show it in the arrow with your arrow? The fourth ventricle or the basal, yeah.
Yes.
From that area. So there's not much of blood concentrating there. So the blood concentrating is in the left sylvian fissure, right?
Yeah.
So where do you think now, which side? At least left side we know. The aneurysm is on the left side. And probably in the, in the anterior circulation. Not in the posterior circulation. If it is left sylvian fissure,
most commonly middle cerebral artery aneurysm.
Sometimes you can have in the anterior communicating artery aneurysm or ACA territory, aneurysm also, but more commonly it is MCA. Okay, so that's how you pick up where the blood is. And so you can say whether it's posterior circulation or anterior, that much at least, or right or left. So this is how the, the neuroradiologist and neurosurgeon will pick up. It's a bit of information for us also. So this is grade 4, isn't it?
Yes.
WFS. So why do you say it is 4?
So SAH is more than 1 mm thick with the intraventricular extension. So it goes into grade 4.
Sorry, not WFNS. This is your Fisher scale, no?
But
Yeah. Okay.
I'll go ahead with the management. So management of this patient, it's general management and the specific management. General management, we had gone ahead and assessed and again stabilized airway breathing circulation and took care of fast track bed, which we routinely do for all the cases, taking care of feeding, analgesia, sedation, thromboprophylaxis, and glycemic control. Then the specific management for this patient, we started the patient on 3% saline for anti-edema measures with continued on an injection levetiracetam 500 mg BD with tablet nimodipine 60 mg 4th hourly.
I have a question here. So you said thromboprophylaxis was also started, correct? FAST, correct?
Yes.
So what's your comment on that? In
So
this,
we'll be starting on mechanical thromboprophylaxis with a DVT pump, ma'am. So here we won't be using any pharmacological prophylaxis because the aneurysm is not secured. So once the aneurysm is secured, the studies have shown after 24 hours of aneurysm securing, we can initiate on a pharmacological DVT prophylaxis.
and what about anti-seizure medications?
Routine anti-seizure medications is contraindicated, not indicated. So we'll be using prophylactic anti-seizure medication in conditions of high grade blood filtration grade of 4 and 5, or if the patient is having hydrocephalus or any cortical ischemia is present or intracerebral hemorrhages is present. So where there is a higher risk of seizure. So in such patient, we'll be using it as a prophylactic. Otherwise, we'll be going only with the therapeutic anti-seizure medications. And we won't, phenytoin is contraindicated in these patients. There are studies which have shown complications with the phenytoin, probably related to its side effects like hypotension and others.
And probably
So we'll be-
arrhythmias also. with
Yes,
it.
ma'am. So we'll be commonly going with the levetiracetam.
Sure. And nimodipine?
So it's a class 1 recommendation in case of SAH. It will be started as soon as the diagnosis is noted and we'll be giving 60 mg every 4th hourly with a BP monitoring. If there are any hypotension, we will reduce the nimodipine dose and temporary stoppage of few doses can be done when there is a severe hypotension. Otherwise, we will continue till 21 days.
But some neurosurgeons, they give like half dose, the frequency they decrease. Instead of 4th hourly, they make it 2nd hourly or 3rd hourly, and they decrease the dose to 30 mg.
30 mg, yes.
So in that way also, they want to maintain the nimodipine dose almost similar, but they reduce the dose and decrease the frequency. Okay.
So I have a question. Why didn't this patient go for intervention?
The next definitive management we have mentioned. So the next slide is up.
Okay, okay.
So this patient was taken up for DSA. In DSA, it showed left posterior communicating artery IC aneurysm with mild spasm of left MC. With this, 4 coils were deployed. This was done on day 2 of the admission. And in the post-operative period, patient was again assessed and stabilized. ABC was assessed and stabilized and continued on supportive care.
So why this was the 4th day of your presentation. So was it indicated because the DSA you have confirmed that there was an already ruptured aneurysm was there? No? Okay. So what is the recommendation? Should we go for aneurysmal definitive procedure? How early you should go?
It recommended within 24 hours or up to 72 hours we can do. Previously, they used to say wait up to 7 to 10 days. If it is not done within 72 hours, wait up to 7 to 10 days and do it after 7 to 10 days. when the edema and the vasospasm is subsided. But again, now in recent guidelines, there is no specific recommendation about delaying the procedure. So they have mentioned as soon as possible, go ahead with the procedure. Ideally preferred within 24 hours, but they have not mentioned when it should not be done, sir.
Okay. Okay, correct. So out of two procedures you told means coil or clipping. So which one you will prefer, when you will prefer? How, coiling when you want to go for and clipping when you want to go for decisions? How you take a decisions for that?
The DRAT trial and ISAT trial have shown benefit of coiling with a posterior circulatory aneurysm. So in posterior circulatory aneurysm, we'll go directly with the coiling. In the anterior circulatory aneurysm, there is no superiority of one over the other. But in the ISAT trial, there was a 7% mortality benefit with the coiling. But over a long period, the mortality benefits or the morbidity benefits is equal between the coiling and clipping. So if the patient is less than 40 years, even with the anterior circulatory, we'll go with the clipping because rebleeding chances will be lower. If the patient is older, we'll go with the coiling because the procedure tolerance with them will be better. And if the patient is having wide neck aneurysm or if the patient is having aneurysm at the bifurcation, the clipping will be preferred than the coiling because of coil migration will be higher, sir. And if the patient is not amenable to any of these procedures, then stenting can be done. But chances of thrombosis will be higher.
Okay. Okay. So before taking the patient for procedure to the cath lab, so what precautions you will take before sending this? Because as an intensivist, we are taking care of the patient. So what precautions you need to take before sending the patient to cath lab, or even intraoperative procedure also? What precautions we need to take?
So in this patient, again, stabilization of ABC is very important and maintaining of normoxia, normocapnia and normal temperature and normal sugar is important. Intraop and while induction, this patient is already intubated. So if the patient is not intubated and we are planning for an intubation, then adequate sedation is important and avoiding of hyper or hypotension is important. And keeping a map more than 80 mm of Hg and avoiding a flat position for longer time should be avoided. Patient should be pre-oxygenated in the head-up position, and once we are taking for an intubation, should be flattened. As soon as the tube is secured, we have to make the patient head up. If the patient is having higher grade, like word federation grade 4 and 5, so intraventricular drainage with the ICP monitoring and controlling of intracranial pressure is also indicated, sir.
Okay. And if patient had a rupture of the aneurysm in the OT or cath lab itself while doing the procedure, so what we will do? Patient at the time of presentation may have a sentinel bleed, so didn't have a complete rupture, for example. So, and intraoperative patient had a bleed, rupture of the aneurysm.
So from our side, again, decreasing the intracranial pressure and keeping the BP 142, systolic blood pressure 140. When there is an acute hemorrhage, around 140 is advisable rather than more than 160. So we'll keep a systolic blood pressure 140 mm of Hg and monitor the ICP. So we'll try to reduce the ICP, but not to less than 20, because even decreasing the ICP less than 20 increases the chances of rebleeding.
Yeah. And for clipping, you need to make the cardiac stand still for a few seconds of time. So
Yes.
by giving some
adenosine will be used most commonly to make the cardiac stand still for the keeping procedures.
What will you do for refractory ICP elevations?
We'll go with a tier 1, 2, 3. By now, already general measures we have followed. And in the tier 1, we already given the osmotherapy.
Reached almost,
and the CSF thing. Yes, ma'am. And next is
tier
the
2, 3 now almost. What are you
Yes.
going to do?
So next is a MAP challenge test we can give. So we increase the systolic blood pressure by 10 mm of Hg up to 20 minutes. We'll monitor the MAP ICP. So we'll see
How
any
are you going to
changes
do
in
it? You have not put in an ICP monitor.
if we, I mean, in the tier 1, we would have put a IVD, ventricular drain, and drain the CSF as a measure to decrease the ICP. ma'am.
Okay, so now let's come to what ICP monitor are you going to use in SAH?
So ma'am, in the higher grade, we will go with the intraventricular drain. So it helps in both for the monitoring as well as a therapeutic drainage of the intraventricular hemorrhage and helps to reduce the ICP as well.
So would you put an ICP monitor, just go back to the CT there? Would you go?
No,
put-
ma'am, in this patient, it is not there.
No, just see, would you put?
Here actually ventricles are collapsed, so chances of going into the ventricle
This
might
is
be
just a cut, I think the cut, because you see the third ventricle is dilated there. Can you see the third ventricle is dilated? So
Yes, ma'am.
maybe if you take the higher cuts, the lateral ventricle may be open on. And there is blood here in the ventricles. Okay. So there's a high possibility that this patient may go for a obstructive hydrocephalus. So EVD may be a good option here, isn't it?
Yes.
So you can see already some bit, I mean, maybe this is too early, but yeah, lateral ventricles may be open in the higher cuts. If you don't have, the lateral ventricles are also collapsed, you don't have an option to place an EVD, what do you go to do?
Other option like subarachnoid bolt and epidural catheters or intraparenchymal.
Is it commonly used?
No, ma'am.
So what do you use?
Ma'am, we'll be monitoring optic nerve sheath diameters on a
Better than
bedside.
that would be
Transcranial Doppler.
transcranial Dopplers.
Yeah.
You can look, see, you've got TCD, which is showing you flow reversal, showing that ICP is elevated. So when you're doing a map challenge test, what can you look at?
So that diastolic flow reversion will be altered, ma'am.
Yeah, you may see your pulsatility index may reduce. The cerebral blood flow also may reduce. So that may tell you the ICP is also coming down. So you can do a map challenge test with the TCD itself. Okay, so if you've not put in an ICP. So that's where the TCD may be very useful for patients management at SAH. Okay, you want to proceed? Yeah.
Shall we go to next slide?
So yeah, my question was, what would you do? You have got a refractory ICP. You've done everything. You've done a map challenge test. Cerebral autoregulation is not intact.
So last resort will be decompressive craniectomy and with flap removal and intra-procedure if intracranial hematoma more than 50 centimeter cube is present to evacuate the hematoma and secure the aneurysm with a clipping if possible.
That should be the option if you have refractory ICP elevation.
Yes.
So on day 3, there was general and specific management, which was mentioned before, was continued with close neuro monitoring. On day 4, patient developed a drop in GCS. Her GCS was E1VT-M2 with a pupillary asymmetry. For this reason, she was shifted for a...
Before you go for a CT scan, what would you suspect?
So patient is already in day 7 of symptoms. So now the possibilities are, one is replete. The second thing is delayed cerebral ischemia in these patients.
So how do you suspect?
Or any seizure episodes which might have happened.
Sure. So how do you suspect the DCI? What would hint DCI?
So one is drop in the GCS by at least by 2 number or more, or if the patient is having new onset of focal neurological deficit in the form of hemiparesis or hemianopia or aphasia, or if the patient is having a CT finding of infarction, so then it points towards the DCI and not attributable to any recent treatment modalities like clipping or coiling.
Yeah, so you have done this CT. So what is it showing?
So CT showed extensive subarachnoid hemorrhage, which was more extensive than the previous CT, which was involving all the cisterns, suprasellar cisterns, bilateral sylvian cisterns, which was greater on the left side with left frontoparietal convexity cisterns and brainstem being hypodense and diffuse subarachnoid hemorrhage involving the bilateral cerebral convexity.
So before we talk about this, suppose it had shown new infarcts, what would you have done?
So that indicates that patient is having delayed cerebral ischemia. So we'll continue the nimodipine and will increase the blood pressure. We'll keep the patient in euvolemic state. We'll assess the hemodynamic monitoring. Most commonly we use on the bedside is the echocardiography with the IVC distensibility or collapsibility based on the patient being on the ventilator. And we'll see if the patient is on controlled mode of ventilator, pulse pressure variation to see for a fluid responsiveness, and we'll keep the patient in euvolemia. Next step will be to augment the hemodynamic. We'll increase the MAP, the systolic blood pressure and the MAP to see for the response MAP. So generally we'll increase by 10 mm of Hg every 20 minutes. There is no recommendation when to, what is the higher maximum blood pressure to be targeted. There are studies which have targeted MAP of 140 mm of Hg with a systolic blood pressure up to 220 mm of Hg. We'll increase the MAP and see for the response MAP.
How
So
are you
the
going to
most
see for
common
the
medication.
response? You'll
So
do
one is by neurological examination we will be doing, and next is the TCD monitoring. So transcranial Doppler we will do to see for the mean flow velocity of
yes.
the blood vessel. And most commonly we use the noradrenaline along with the normal saline for MAP augmentation. If the cardiac complications are present in the form of decrease in the ejection fraction, even milrinone will be helpful. It also causes the vasodilation along with the cardiac augmentation.
Yes.
The next step is intravascular therapies, that is intraarterial vasodilators can be used. Most commonly used is nicardipine and milrinone. If that is not helpful, even the angioplasty can be done.
Correct. So now what has happened here? In this case, it is not DCI. No?
It's not,
The rebleed, which is
So why do you think this patient had rebleeding despite your intervention?
there was the patient presented late to us. The coiling was not done earlier, ma'am. It was done on the day 4 of her presentation. That might be one of the reason for it. And it was a high grade subarachnoid hemorrhage, so the chances of rebleeding was again higher in her. So these two might be the contributing factors for her.
What are you going to do next?
so rebleeding, even after the procedure, the mortality and morbidity will be higher. So the papers which have published, when they have done clipping to these patients who had a rebleeding after coiling, they have shown almost 100% mortality. So the condition was discussed with the relatives, and also there was hypodensity in the brainstem. So we suspected probably it could be because of raised ICP and compression, or it could be because of a DCI. So where the prognosis will be poor. So this been discussed with the family members, and they opted for a comfort care later.
You can see that there is diffuse cerebral edema
Yes,
with
ma'am.
loss of gray white matter differentiation and probably even herniation. You see
Yes,
the-
ma'am. So
What are the other methods to detect DCI? Oh, so you told already do a CT angio and TCD. So and any other methods to detect DCI, vasospasm and DCI?
even the continuous EEG monitoring can be done to see the DCI effects, sir. So where the alpha activity will be reduced, and intermittent epileptiform discharges will be there, which is more specific to it. And variability of the alpha activity will be seen. Alpha to delta ratio is also reduced.
Yeah, okay. Any other method? Any other new interventions or anything?
It may ask you questions on multimodal monitoring.
Yes, yes.
So you may need to know some bit of information.
Maybe we may not be doing, but at least theoretically we should.
Yeah, TCD, yes.
Infrared spectroscopy is also one of the options.
Multimodal, what are the things that you will look at? What is being mentioned? Brain tissue oxygen.
So we'll look at the brain tissue oxygenation, even the brain microdialysis to see for the pyruvate to glutamate, pyruvate to lactate ratio and glutamate levels.
Then jugular venous oxygen saturation. A lot of, especially in trauma, there are a lot of protocols combining all of these.
Yes.
But TCT, yes, it plays a major role in management of SAH and continuous EEG. I think we have come to the end of the case.
Yeah. And one more thing, if patient, what are the other differential diagnoses you will think at the initial presentation? At the initial presentation, because initially before going for CT clinically, once you have done CT, sometimes you may not get anything initially, and you want to, after 6-hour presentation, you want to confirm with a CSF analysis to confirm, look for xanthochromia. You are confirming that there is a possibility of subarachnoid hemorrhage, or you go for a CT angio or a DSLF when highly suspected case of the subarachnoid hemorrhage. But besides subarachnoid hemorrhage, when you don't get any non-contrast CT within 6 hours, what are the other differential diagnoses will have when patient comes to you with altered sensorium, with severe history of severe headache? What are the other differential diagnoses you will have?
So intracerebral hemorrhage, cerebral venous thrombosis, or meningitis could be a possibility. Sir.
Any other conditions? This patient had a hypertension.
No, sir. She didn't had any comorbidities.
Comorbidities didn't have. But at the time of presentation, the patient had a accelerated hypertension. Okay, so if patient had a
accelerated hypertension with
accelerated
Rett
hypertension,
syndrome.
you can think of hypertensive encephalopathy.
Yes.
Yeah, patient can have, yeah. Any other condition underlying some disease, if it is there, you don't have a high suspicion, but a kind of non-aneurysmal bleed, or if it is a CSF, there is a initial patient may not have, but if you do a confirm with DSA, you may find that there is a findings of
heavy malformation and
heavy malformation. Okay, underlying disease, anything?
CNS vasculitis also. Okay.
Yeah.
And connective tissue disorders.
Yes, connective tissue disorders or sickle cell disease.
Okay.
The patient having an underlying sickle cell disease, also patient can have a severe headache, and patient can present to you, but initially non-contrast CT may not give you any finding. Then again, if you do with DSA, confirm the diagnosis, or once you do the any other additional findings in the peripheral smear, that may give you clue regarding the presentation, like crisis conditions. Maybe additional findings will help you in the if underlying disease is there.
Okay.
Okay. Okay, so related to management, anyway, you have discussed everything related to management, related to how to reduce the intracranial pressure, how to control prevent vasospasm, and role of IV fluids, and euvolemic status, and all the things you have explained, answered well, and ICP monitoring, role of, and different clinical difficult scenarios where clinical, suppose some patients, they may present with hyponatremia, severe hyponatremia. So hyponatremia, how will you find out the etiology, and how will you manage the hyponatremia?
So in these patients, it could be because of most commonly, if the patient present with the onset of, on the day of admission, if the patient is having hyponatremia, it could be because of hypovolemic or underlying, the patient could be chronic hyponatremic. Or if the patient developed after this acute presentation going into hyponatremia, the most common cause is SIADH or cerebral salt wasting disease. So in case of SAH, volume will be euvolemic. In case of cerebral salt wasting disease, it will be hypovolemic. In both the condition, urinary sodium will be more than 40 millimole per liter. And urinary excretion of uric acid even will be higher, and serum uric acid will be lower. So main differentiating feature is volume in these patients. So in case of SIADH, again, the fluid restriction will be helpful, but in case of SAH, we will be avoiding fluid restriction. So maintaining input-output balance being neutral will be sufficient. In case of cerebral salt wasting syndrome, we need to supplement with the normal saline.
What common sodium abnormality you're going to expect in this patient? Hypo or hyper?
Hyponatremia is common. Even hypernatremia can happen with a diabetes
Since
insipidus.
the patient has come within 4 to 5 days, no? You're going to expect hyper or hypo?
Hyponatremia. No?
Hypo or hyper? Patient is having such a severe cerebral edema. He's probably even coning, no?
So even
It's
that
going to be hypernatremia, no? Because
Diabetes
it's
insipidus.
probably going into DI. You'll need to stop the 3% saline soon, correct?
Any role of mineralocorticoid?
Fluorocortisone is recommended in cerebral salt wasting. No definitive evidence, but it can be suggested that it can be given.
I think.
Done, sir.
Yeah.
I think everything is been covered. I think
Yeah.
you
Yeah.
answered very well.
Yeah, they
So,
answered very well. Very
Yeah.
well.
yes, ma'am, I think. Good. So basically just last 1 or 2 questions, ma'am, especially Madam Bhuvana Krishna, madam. I think you might have seen like DM courses there at your center and all, might have seen a lot of students. So as a DRNB candidate, when they go to the exam, appearing practical exam, what do you think? What are the different tips that you want to give to them? How to like prepare and how to present at that on the day of the exam?
If it is pertaining to a neurological case like this, I think they should be comfortable in examining the patient in an altered sensorium, a complete neurological examination, having a systematic approach, how to examine the patient and all. What are the key things that they need to look at, like the cranial nerves, which cranial nerves, like you mentioned, gag was there or some things were mentioned. So you should know what to examine. Head to toe, have a format. So all the vitals, the general examination, what are the infusions that are going on, what's the sedation what's going on, what is the score, and then neurological examination like in this patient, because that will be very, very important. And summarize, you can start off with an opening statement saying, I'm presenting a patient with a 61-year-old lady who is presented with an aneurysmal hemorrhage, subarachnoid, and hemorrhage due to an aneurysm. We can start off with that and then summarize quickly the history and all the important findings and follow a format. Differential diagnosis after the history, and you'll have to come to narrow down your diagnosis after you've got the examination. And keep practicing so that you are comfortable in following the format, so that you don't give any pauses and breaks and where the examiner has to ask you leading questions. You should interpret, like you found a heart rate of 90. What is your interpretation? You found a blood pressure of 130/80. What is your interpretation? So every piece of information that you find at the bedside, you give your input with relevant to the case. I'm okay with the heart rate of 90, or this blood pressure of 130/80 is off vasopressors. For a patient with subarachnoid hemorrhage, this is a good blood pressure target in the initial stages, like that. So when you mention that, the examiner knows what you're looking for when you're examining the patient. And quickly finish your presentation, and then so you have enough time to allow the examiner to ask you questions. So your presentation should complete with even your investigations. A quick look at ECGs, X-rays, CT scans, and the chart, like simple thing like input, output, the sugars, the temperature, so that you can tell them, this is what is this thing, and then your plan, what you're going to do next. So it should be smooth, and you'll have very limited time to present. So you should practice to complete to reach to this thing.
Yes. Yeah, Prusti sir, as a senior clinician, you have seen a lot of students like this, and you are still teaching very well to all the students. So, what are your tips, sir? Like,
Yeah, so I agree with Dr. Bhuvana Krishna. So what she told, neurological examination is very, very important. So here, what I will say is, in the neurology particularly, we need to understand two things. Examination in a conscious patient is something different from a patient who is presenting to us with altered sensorium, because we may not be able to examine completely neurological examination in altered sensorium patient. So some out of A, B, C, D, whatever the examination is there, like higher function test, cranial knobs, motor examination, sensory examination, spinal cord, cerebellar science, different examinations are there. We have to be selective that which are the important parameters we need to examine in an altered unconscious patient. So those findings we need to remember, and we have to make a practice that examination in unconscious patient from a conscious patient. That is one. Second is two diagnoses you have to make. One is your anatomical diagnosis, another is etiological diagnosis in a neuro case. So anatomical diagnosis, you need to find out where is the lesion. So a patient, whether it is in the cortex, whether it is in the brainstem, spinal cord, peripheral nerve, or in the neuromuscular junction or a muscle. So that is anatomical diagnosis. Then etiological diagnosis, what might be the etiology depending on the site of the lesion. So these two things, your approach is correct. You reach at the diagnosis final, and your approach will be 100% right, and your answer will be you have done all the things, because next how to evaluate and all those things you can answer easily. That is not a big issue. That's what I want to highlight.
thank you, sir. So, this is one platform where we are conducting this masterclass almost near to 3.5 years, ma'am. Our students get exposure to various very good examiners across our nation, India. So that is the advantage. They are most of the students, they had given feedback that they revisit these lectures before their exam, and being helpful. I think we are doing our bit. So thank you very much, Dr. Bhuvana Krishna madam, and thank you very much, Dr. Saroj Prusti sir. And thank you, Dr. Preethi and Dr. Dhanushree, for bringing out that case and have had a nice discussion on that. So thank you, Yashoda Hospitals and our digital and branding team for providing the platform.
Thank
So,
you for the opportunity.
Thank you.
Yeah.
Good
Thank you, Dr. Kaladhar, Dr. Venkat, and thank you, madam.
Thank you, Dr. Saroj.
Yeah.
And good luck for the students.
Thank you.
Thank you, Dhanushree and Preethi. Yeah.
Okay. Thank you, sir.
Take care. Good night.
Good.
Thank you. Good night.
Well presented.
Thank you.